I can see Matt's face. Matt, does it look okay? Good. Okay, fine. Cool. Everybody can hear me. Everybody can see the slide. Good. So we will deal with CT of abdominal and parenchymal organs. And there's 2 talks, one now and one in 2 weeks, I believe. And on the first today, we're going to basically deal with liver and gallbladder. So CT is more and more used for abdominal workup in dogs and cats and also in rabbits. I have a little bit of rabbit stuff in here as well. Because it's just, it's really quickly done. You get lots of morphological information. You can do this regardless of the size of the animal pretty well. So it has become a real competitor for ultrasound, for which there's obviously still lots of applications, but it's cool to see all the things you can identify on CT. That is useful because vets just do this now. You know, they don't ask for your permission to do a CT for intestinal foreign body or whatever. They just go ahead and do it, and you have to interpret it. So even if you're like, oh, this doesn't need a CT, the ultrasound would be quicker, you got to be able to identify all these different disease categories using CT people, because it just happens. So here we go. We'll start with the liver. And here I got a little bit of, I'm just going to make these windows a bit smaller. The canine and feline hepatic anatomy, which I had to flip images around because they're displayed the wrong way around. So I've displayed them in how we see them as radiologists, and different textbooks give you different definition what a liver lobe is. But it is important to understand what these parts of the liver are, because they're not so well visible as separate organs. So you need to have a rough idea where what is what. So the most cranial part of the liver, you got the medial lobes, the left one and the right one. And then further caudal, you have the lateral lobes, the right one and the left one. In the dog, the right medial lobe and the left medial lobe are roughly the same. But on the cat, the right medial lobe is much bigger than the left one. And you can see that on radiographs, ultrasound, and CT as well, that the right side of the liver in the cat goes more caudal than the left. That's a normal feature. So then that's an interesting thing that we'll need in our daily practice. So then the caudate lobe has 2 parts. You know, technically some people call it different lobes, but in this categorization it's 1. So on the right, the caudate lobe with the renal fossa. It's a caudate process of the caudate lobe, has the renal fossa for the right kidney. That's, oh, you know what? When I show something on my screen with my mouse, you cannot see that. Is that correct? And I need to...
I can see Tobias.
You can see my mouse?
Yeah, they're saying they can see it.
Okay, cool, good. I will try not to be too annoying with it, but if I want to show something, I can. So the caudate lobe has the renal fossa on the right, whereas on the left side, you have the papillary process, which just kind of hangs over the porta hepatis here. And then you have the gallbladder, which is surrounded by the right medial lobe on the right side and the quadrate lobe on the left. And these 2 lobes are really cool landmarks. So if you have a mass and it sits directly left of the gallbladder, it's going to be quadrate lobe. If it's directly on the right, then it's going to be the right medial lobe. So those 2 lobes and the gallbladder margins, these are useful things to know about. Okay, to advance the slide. Other way, fine. This is from a textbook chapter where we listed all the relationship between different structures relating to the liver. And again, this is helpful because you don't normally see the lobes as separate things. So knowing what's beside what is cool. So already we discussed the gallbladder. The other one that's helpful is the esophagus, here in American spelling. So because that sits between the left lateral lobe and the papillary process of the caudate lobe. The porta hepatis sits between both parts of the caudate lobe. And actually now, if I would redo it, I would put the left side on that side because it just would be better. Okay, I'll add that for next time. And the ductus venosus, so if you have a left divisional portosystemic shunt, then that is basically the embryological remnant of the ductus venosus. And that runs between the left lateral lobe and the papillary process. And the caudal vena cava sits between the right medial lobe and the caudate process. And the falciform ligament is between the left medial lobe and the quadrate lobe. And that you can see sometimes a lot of this falciform fat or livers that are kind of particularly split in the middle. So you then know exactly between which two lobes that is. If you look at the liver in a cranial to caudal dimension, axis, plane, then the caudate lobe is connected, is adjacent to the right kidney. The left lateral lobe is adjacent to the stomach. And the right lateral lobe and the caudate process of the caudate lobe are adjacent to the duodenum. There's actually an impression in the liver for the duodenum as well. It's pretty small. Okay. When you have a dog or an animal with peritoneal effusion, then you can see the lobes really well. And I'm sure you will come across those, and I would urge you to cherish this and to burn this into your hard drive of where those margins are. So here is, this is a dog. I'll show you, I think, a cat as well later on with ascites as well. So again, very cranial. You can see the right medial and the left medial lobe, and then here would be this falciform fat between. Here's a gallbladder, and so therefore left to it must be the quadrate lobe. You can see here how the medial and the left medial lobe, how they are connected still. And also on this second slide, you can just see how the left lateral lobe starts. And then you can see the left medial lobe, it's the end here, and more things caudally become left lateral lobe. If we go to the lower row on the left, you see the gallbladder again, right medial quadrate lobe, and a little bit left ventral of the left medial lobe. So often you see that bit on CT a lot, so at that level. So, and then further up, that's all left lateral. So, and I think that gives you some really good, you know, navigation of where you are. And again, further caudal, here are the two processes of the caudal lobe, the caudate process and the papillary process with the porta hepatis in between. And most caudally, what you'll be left with in a dog, if you go really caudal, is the right medial and left lateral. Let me just see, I think there might be another slide coming. Yeah, we're not at the end yet, we're still going. Because I think, particularly at this level, it's some sort of not always so sure what bits of liver we're looking at here. So here, further caudal, you eventually have a bit of right medial, dorsal right lateral, and then ventrally here, this is all left lateral left. And you can see that the left lateral here on the very last bit is here, and the last bit that we see in this particular dog is the caudate process. But yeah, the left lateral goes pretty far in the dog. So, and I think now we're gonna see, we'll see it in the dorsal plane. Again, we're starting from dorsal going ventral. You can see that the lateral lobes, they're more dorsal located in the cranial part. and the medial lobes are a bit more ventral. I think in the lower images, you can see left medial, right medial, and then here's the lateral lobe, how that splits up, and the relation to the spleen. And here we got the cat. Again, cranially, right medial lobe is relatively small and lots of left medial lobe. And as you go caudally, the right side contributes more to the liver. I think that's another one as well. So yes, so here you can see, I think that's the big difference. So in the cat, on the lower image, you can see that right medial lobe sticking far caudal. So in the cat, it's the right medial one that sticks most caudal. In the dog, it's the left lateral that sticks most caudal, more or less. So that is a big difference between the two. Okay, I think I went the wrong way. Here we go. Another common quiz question in various exams is the bile duct anatomy, which I'm sure you're familiar with, but it is an important distinguishing feature. So let me start with the dog as kind of the default. Then there's at the major duodenal papilla, there's one papilla which has two entries from two different structures, the pancreatic duct and the common bile duct, but the ducts are separate. And there is always an accessory papillary duct, and that's at the minor duodenal papilla in the proximal descending duodenum. Whereas in cats, on the left, the pancreatic duct joins the common bile duct, and then together they exit the duodenal major papilla. And only 20% of cats have an accessory pancreatic duct. And because of this anatomy, this was, I think it's a bit not so en vogue anymore, that whole concepts of triaditis in cats. Because all these juices are mixed here, so if you have infection, inflammation in one part, it goes to the other one. If one duct is blocked, it blocks both, and they don't have an additional exit from their pancreas, and that's why this all gets together inflamed. And there's now more recent research doesn't really focus on these anatomical difference, but it's probably a contributing factor. So those are important anatomic landmarks and differences between cat and dog. When we look at parenchymal enhancement, and I think there's coming a little bit more on this one, but this is just maybe an overview of parenchymal enhancement anywhere. So in principle, you always have to think of that when you inject contrast into the peripheral veins, goes to the heart, and then it goes into the systemic arterial system. So therefore, organs in the abdomen should normally get their maximum contrast enhancement from their arterial supply, because arteries supply blood and veins drain it. So it just, therefore you should get the most contrast enhancement early on, because the contrast medium is less diluted with non-enhanced blood. However, because of the abdomen, we have the portal venous supply. So a lot of blood is actually supplied to the liver, at least by the portal vein, about 80%. Then the timing is a little bit different. But this doesn't apply to the other abdominal organ, which have portal vein drainage, but not portal vein supply. So for instance, pancreas, which we'll come back to in the next lecture, is it has a strong arterial blood supply and a mild portal venous enhancement, because basically there's more of it, and particularly for insulinomas, they are supposed to have this stronger arterial blood supply. But this doesn't always hold true, unfortunately. And again, we'll discuss that in more detail. About the liver with the blood supply and the contrast enhancement. So in the ideal world, based on human medicine, most liver neoplasias do not have a normal portal blood supply. They are supplied by the arteries, hepatic arteries, and therefore they should be strong on arterial phase and less strong on portal phase. And we've done some trials, and other people have done that too. And we find that this is not really 100% reliable, because it would be wonderful if you could characterize all these nodules into aggressive or, you know, incidental hyperplastic nodules, but I don't really think this holds true. Hence, question mark everywhere here. So it's to be taken with a grain of salt. However, one thing that isn't really much used so far is the relationship between contrast enhancement in the liver and in the pancreas. In the arterial phase, the pancreas contrasts enhance more than the liver, much more actually, which makes sense because, as we just said, the liver receives 80% of its blood supply from the portal vein, which happens a bit later. So then during the portal vein, the liver is usually a little bit more contrast enhancer in the pancreas, but often you don't really see them very distinguishedly different. And in the late phase, and that is something like 10 minutes, the pancreas is less enhanced than the liver again. Is less enhanced than the liver. And that one is an interesting phase. So when you look at the body of the pancreas, it's directly adjacent to the liver. And so it's sometimes it'd be nice to know exactly where the liver stops and the pancreas starts for various reasons. So if you have the opportunity to scan them again, or the dog's still on the table and you can wait 10 minutes, then often you can see that the liver is more contrast enhanced than the pancreas. And the reason for it is likely that the liver has a biliary excretion of contrast medium, and that's why it enhances within 10 minutes. And I found that this was more pronounced with the non-ionic contrast medium, which we don't use anymore, but I think you can still see it on modern non-ionic contrast medium. Sorry, I meant to say earlier days we used ionic, but now on non-ionic you can still see that. So here are some examples for this. So on top left, number A, you got the body of the pancreas here, right pancreas, left pancreas, and the liver. And in the arterial phase, the pancreas is much more bright. Portal phase, liver is a little bit brighter than the pancreas in this particular case. And 10 minutes post-contrast, the liver is much brighter than the pancreas. So it's just another feature that helps you in your assessment of complex cases in this area where everything is kind of a lot of bunched up there and there's not much fat to see things. So something we can do. So biliary excretion of contrast medium is something you will see both with iodine and gadolinium-based contrast media. And we haven't done any long-term study about it, but it usually, if you want to use contrast medium for biliary diagnostics, then waiting for an hour is a good idea. And why is this? Because iodine-based contrast medium is supposed to have 100% renal excretion. And for those of you who have studied GFR calculations based on imaging with scintigraphy or CT are based on that the 100% is excreted by the kidney. But this isn't really true. There is a small percentage that is biliary excreted, even in dogs that don't have liver disease, that don't have renal disease. And therefore you will see something eventually in the bile ducts. And then when it accumulates in the gallbladder, then this can be on the top or on the bottom. And that depends on the specific gravity of the bile that was already in there. So unfortunately, you can't really make diagnostics out of whether the biliary contrast medium is dorsally or ventrally, or depending on your decubitus of your dog, positioned. That can be incidental, basically. So this paper from my colleagues in Sydney and friends, so they used this gadoxetic acid, and it's a specific hepatobiliary contrast medium. You can use it for MRI and CT, and you can use it, and based on their study, 20 minutes post-injection, you can see something, but ideally also around an hour, 60-65 minutes. And again, they explain this with K-edge of gadolinium and iodine. It didn't have any adverse effects, and it's reliable to see the gallbladder and the common bile duct, but not the cystic bile ducts or the hepatic ducts. And it, according to their study, it pulls non-dependently. So if you want to see that, then contrast medium in the bile ducts, you should put them in dorsal recumbency. I hope I interpret this correctly. If one of the authors is here on the talk, you can correct me if I'm wrong. Now, these are some examples of contrast medium accumulation in the biliary system. On the left is a dog that just had an MRI 1.5 hours before, so you can see the contrast medium accumulating there. And on the right is a cat that has a pleural effusion, and it does have increased lymphatic and biliary contrast medium excretion. And you see that quite a lot in animals that have lymphatic drainage problems. I don't really know what this is. I think this is a desperate attempt of animals to get rid of their contrast medium, but it's not normal, but you can see that. So, and I think on this one, you don't really see the cisterna-chyli contrast medium, but you can see that sometimes as well. So let's go through some of the parenchymal disorders. So micropathia, hepatomegaly, cirrhosis, infection and inflammation, hyperplasia, neoplasia, lipidosis, torsion, edema, and then trauma. So loss of liver volume, you can either have that generalized or have a particularly lobar atrophy. When you have a generalized loss of liver.
Before you move on, we've got a question about that.
Yep.
From Antonia. Do animals with renal disease also have increased biliary and lymphatic excretion?
Yes, I think they do. Now I see this most, I go back actually to that image. Oops, no, wrong way. I see this most commonly in cats, older cats with chronic renal disease. And the lymphatics excretion is a desperate attempt by the body to get rid of it, which doesn't work because all the lymphatics do put it back into the blood supply. And then it goes to the kidneys again, which again don't work. But with the biliary excretion, at least they get rid of it. And you will see that also in the colon as well, that they excrete contrast medium in the colon. You can see it on radiographs as well. There's also the contrast medium in there. So yes. Okay. All right, we'll go back to loss of liver volume. And here's an example of a dog, a young dog with micropathia. By the way, it's micropathia, not hepatica, commonly misspelled. And so you can use gastric axis like in radiographs if you find the stomach. But I think on CT, what's much more obvious, which I never observed on ultrasound, is so that the gallbladder often becomes really big. And I don't really know 100% why this is, whether the gallbladder is actually normal, it's just the rest of the liver is smaller, or that there is a reason why the gallbladder lumen is really enlarged. But it's very, it just jumps into you. On this one, maybe not so much, but on normal like here on this transverse image, you often see in these small livers that the gallbladders are really big. This was a dog with a shunt here. And you can see how little liver there's left cranial to the gallbladder. So I think that's an interesting phenomenon, because first you wonder like, oh, why is the gallbladder big? When then you only realize that actually, most importantly, the liver is small. So yes, we can see that the liver is small. And okay, something else coming here. And another thing that you sometimes see in large breed dogs, I don't know why, but I've seen it most commonly in large breed dogs like Great Danes, this is a Labrador, that dorsally the liver atrophies. And you can see here that on the right image, that the colon, the stomach, and the spleen, they all touch the diaphragm here because there's no more liver. There should be liver from here to there, everywhere. And it's just not there. We're not that far off from midline here, while the ribs are coming out. Yeah, we are pretty close to midline. There should definitely be liver. So again, I don't really know why these dogs have this or whether this means something. But you can definitely see that in my experience in large breed dogs, that they have this dorsal liver atrophy. Liver cirrhosis is something we don't see as commonly as in human patients, but we do see it. And the most common description of cirrhosis is that the liver becomes smaller, but actually cirrhosis isn't always small, and it's not always small in all stages. It's basically this fibrous replacement of liver tissue, and that can also have an enlarged phase to it. But what it does do, it does make the liver look bumpy, and you can see all these kind of rounded surfaces here everywhere. And it's very typical of liver cirrhosis. So, and when you look at them, the contrast enhancement, it's reasonably homogeneous. So they're unlikely all like individual malignant or benign nodules. And this is a very typical look for cirrhosis. They shouldn't have these rounded edges. Lipidosis in the liver, or steatitis, is visible if it's marked because CT is very good in picking up density, and fat is less dense than soft tissue. And what you see is a mirror image density display with vessels and gallbladder being brighter than the liver tissue. I've always seen this together with obesity. You can measure this, and we're working on quantification of this. So you could do this like an osteodensitometry. And my colleague, Mrs. Gumpenberger in Austria, has already established reference values and tortoises. And she just told me that she's just about to publish this now, which is about time. So if the liver is less than 20 Hounsfield units in a tortoise, then that's a sign of steatosis in the liver and in them. And so CT is really useful there because it's easy to do. It's a common condition in tortoises, and it's very visible. So let's see what I have here to show you. So here is a border collie with diabetic ketosis. And you can see that the liver image is basically mirrored or inverse. So the gallbladder is relatively dense. You have dense vessels, and they're surrounded by much less dense other structures. And the diaphragm here as well. So this is obviously an extreme case, but yes, so this is definitely a lipidosis. You don't need an aspirate for this unless you want to quantify that further. Congestion looks also really interesting in CT. This is a young dog with right heart failure, and this dog has hepatic congestion, and you can see the kind of marbled appearance between parenchyma and kind of fluid dense spaces, and that's probably perivascular edema that you're seeing here. And this is post-contrast, so sometimes organs like the spleen look a little bit like this, but the liver really shouldn't look like this. And you can also see here that it's everywhere in the liver. And that suggests it's not some sort of local perfusion defect or something like that, something that affects the entire liver. So that's how congestion looks like. And I'm not aware that there are any studies on this. We don't see it very often, so I just have an example where I have this. Budd-Chiari syndrome arises from human medicine, and the true Budd-Chiari syndrome has occlusion of the hepatic venules that lead into the caudal vena cava, and then a resulting basically caval stenosis. But most lesions are not these hepatic venules, and that's why they're called Budd-Chiari-like lesions. And there you are dealing with some sort of caudal vena cava, abdominal or caudal thoracic obstruction or constriction. On the left, or that's both the same. So this was a dog that had a fibrosis, possibly some sort of foreign body reaction. Foreign body was never found. And he had ascites as well. And so you can see here this constricted caudal vena cava in the liver. And that was then carefully dissected out. So we verified that that was really the cause of the abnormality. However, in other cases, particularly when you see that stenosis more in the junction from the liver to the thorax, the diaphragm area, this is highly positional. So inspiration, expiration, recumbency, all that plays a major role. And unless you're doing some interventional procedure where you balloon it or you catheterize this to see what this vessel really does, I wouldn't recommend taking this as face value that you just see a small cava and therefore this is a Budd-Chiari-like syndrome. There'll be many errors in this one. But if it is real, this is kind of what you should expect to see. And then we come to the periportal halo, which is something we kind of noticed and reported many years ago. And so you can see this maybe best on the image on the right. So this is the portal vein, and you can see a black rim surrounding the vessel lumen. And then there's also a rim actually around the caudal vena cava. Also on the left image, you can see that. So what is that? Well, this is called portal wall edema. It's in humans recognized as a non-specific sign. Could be edematous, inflammatory, or possibly infiltrative. And we do see this in dogs. Some have shunts, which is why we do CTs nowadays, and some don't have shunts, and we don't really know what this means. And as far as I'm concerned, I tried to do a study and correlate that with liver values once, and it wasn't really conclusive, but we didn't really have enough cases. But I'm not aware of any study who has basically correlated that to histology or any kind of clinical science to validate whether this periportal edema is of clinical importance or not. I tend to see it in small dogs. And I think I see it occasionally in cats as well, but I don't think I see it in large breed dogs, but I could be mistaken there. Okay. Be interesting to hear your experience with these periportal halo at the end. Good, let's talk about liver lobe torsion. So it's not common in dogs and cats. They can have an acute or chronic presentation, but it's non-specific, vomiting, lethargy, anorexia. And in dogs, the left lateral lobe is most commonly affected. Again, that's where knowing this anatomy helps. And surprising to ourselves, in rabbits, this is a common condition. And since we now scan more and more rabbits, we do find it occasionally. And in rabbits, the caudate lobe is the most commonly affected. So here's an example of a 5-year-old German Shepherd with the left lateral liver lobe torsion. So in the anterior phase, you can see that this is bright, the liver here, contrast enhancing, but there is a filling defect in these vessels, which we don't know what it is yet. And in the venous phase, these vessels remain unenhanced. And then you can see the swirl sign that has been reported by Schwarz, as well as you go cranial and caudal. Let me see whether there's another image coming. No, that's a different one. Let's go back here. And also then you can assess the malorientation here. So again, in the dog, the left lateral lobe is the one that sticks out most. So that's why that has to be the right lateral lobe. So when you go through the images, it does make sense to liver lobe torsion. It's maybe a bit difficult to capture from 2 single images here. Here is a 4-year-old Pyrenean mountain dog, and it has a left lateral liver lobe torsion as well. In this one, you can kind of recognize the torso anatomy, the malposition of the left lateral lobe. There is a fat stranding here, and then this swelling. And again, here on the right, you can just see little arteries, but the veins here, the portal veins, they remain unenhanced, thrombosed there. And let me just see if there's another image of that one. No. So sometimes you can see the swirl, but I didn't include that here. Now we come to the more common pathologies of nodules and masses. Nodules and masses are basically the same. It's just a definition of size. Often
we've got a comment here.
Yep.
From Torsten Rick, which I believe was about the periportal halo. And the comment is, in the book of Berolini, it's described as lymphatics. Do you want to comment on that?
Okay, that's interesting. So when I discovered that first, like 10 years ago or something, I did dig into it. I found some articles, but I don't remember that they were saying they are lymphatics. Could be, but what is really striking is that the wall of these vessels is circumferentially enlarged. It's not just one side, but I guess it could be a lymphatic drainage issue affecting all of it. Yep, that's all I can say. Okay, good.
And we've also got a comment from Nicole Hearn, saying, my impression from the human literature is that it is periportal edema and or dilated lymphatics. Oh no, sorry, that's from Heather. Sorry, Heather.
Okay, good. Well, I guess I have to do some reading there. I just find it a bit odd that they are so evenly distributed over the whole liver then, if it's really lymphatic drainage. And also, usually the hepatic lymph nodes are not really enlarged with them as well. But yes, we'll have to have a look into that. Okay, continue.
It also says, I don't think it is established in dogs.
No, as far as I know, nobody has done. It's hard, obviously. These dogs are not sick enough to get a biopsy from this. So, and a vascular biopsy isn't really a fun thing to do anyway, so.
Okay, I think that might be it.
Okay, good. We'll continue with liver nodules and masses. So I just have left to right 2 confirmed cases. Left is benign hyperplasia. On the right is a histiocytic sarcoma. There's nothing really distinguishing these 2 from each other. They're both in the portal phase, more or less. So, okay, we don't know what these nodules would have done in different phases, but also the reality is when you review cases with abdominal CT, they don't all have 3 phases, you know, arterial, portal, and late. So you're going to have to deal with things like this. There's a poorly or non-enhancing nodules in the liver, and I don't think we have really cracked this at all of whether these are benign and malignant. I think what we can do and should do is to look at the other things in this animal. Are the lymph nodes enlarged? Are other organs enlarged? And that's what we all do. And then you put this in contexts. But even then, you do have to recognize that because benign hyperplasia is incredibly common, it's not really an extremely unusual. It wouldn't be extremely unusual to have a second disease independently because hyperplasia is common. So it will be difficult to be 100% confident about these ones. I am not. Okay, so let's talk a bit about approach to hepatic neoplasia. We kind of did already a little bit. And I just want to mention a little bit RECIST. I'm sure those of you studying for your exams are familiar with this, and those of you who work together with oncologists, they are also familiar with that. And the story about RECIST, which stands for Response Evaluation Criteria and Solid Tumor Criteria. The story is that this was something used in chest CT in people, started about maybe 15 years ago. And when the CT scanners were not really that good yet, so all you could get is your transverse CT, and the oncologists wanted to have a quantified, measurable, reliable tool to assess tumor progression. And a lot of it was also driven by drug testing. If you use a new drug in cohort A and not in B, you needed to have some sort of quantifiable results to assess it, whether the drug worked or not. But this has now spun out, some argue out of control, to use on everything, every tumor. We're not just in the lungs anymore. Anything you can measure it. And there's different versions of RECIST, and every client are always happy to have something measured, which I think is part of the problem, because just because you measure something, you don't necessarily create accuracy. But first, we're just going to go through what it is that you're supposed to do there. Then we can discuss how meaningful that is. So the idea is you're not doing reconstructions in any other plane. You just take the CT as it is, transverse, however you position it, that's it. And then if you find a lesion that you can measure, something you could cut out with a scissor basically, you measure whatever longest distance you can find in that thing using the axial planes. And that's called a target lesion. And then if you have an organ that has more than 5, then you cannot do RECIST anymore. It cannot be more than 5. Because on follow-up, it's too complicated to then link this, which nodule was which. And per study, so everywhere, whatever you scanned, you can have more than 10 of these lesions because it's too difficult to follow. And then what you do is you sum up all these TLs, these target lesions, lengths, to the longest distance. So this is then the sum of the longest distance, and that's your result. And that's what you compare between different observation points. And if you cannot measure it because it's too diffuse, or looks like there's some necrosis in it, or there's a cyst, which is unlikely to be neoplastic tissue, then that's called a non-target lesion. and they should not be bigger than a centimeter to be included in the score, so to say. Yes.
So you've got 10 minutes left.
Okay, cool. We'll see where we are. I don't think we're too far off. Hepatocellular carcinoma is the most common malignant hepatic neoplasia. It can give you nodules, a big mass, or it could be diffuse. It doesn't like to metastasize. And if it's a big mass or single mass, you can cure it by surgery. So that's important. But because these masses are big and they often don't contrast enhance well, they have a modified RECIST criteria which measures the interarterial contrast enhanced areas only, and that matches better with embolization. Because when you embolize these tumors, it doesn't shrink the tumor, but it does reduce the interarterial enhanced area. And here are some examples of hepatocellular carcinomas. I'm sure you have seen similar ones like this in different phases. So the arterial phase picks up less of it. This one wasn't embolized, so it wouldn't have shown anyway, but you can see the difference between the arterial and the later phases. And if you wanted to measure this, then this is an example, the difference. If a normal RECIST, you would measure the whole thing. And if you do an M-RECIST, you would only measure the arterial thing. You would get a different results with that. So that was an example. Hepatic lymphnodes, there's two of them at the porta hepatis. One is left dorsal and one is right ventral to the portal vein. And if they're enlarged, you should suspect hepatic pancreatic pathology, but also you can have thoracic pathology with them. I've seen that a number of times. So here are the normal hepatic lymph nodes. So they're usually at the 2 o'clock and 7 o'clock position. And here you can see an enlarged hepatic lymph node. And we're coming to the end, talking about hepatobiliary disorders. Cholelithiasis we can commonly see in dogs on CT. Another reason why it's really important to have a pre-contrast CT. It's often incidental, obviously depends where it is. If it's in a common bile duct, then often these cause obstruction. And yes, just because you see one doesn't mean it's definitely obstructive. Maybe it's still moving around, depends on the context. So here's an example of cholelithiasis in the gallbladder and in the common bile duct here on the right, pretty big ones. And you can also see that the bile duct here dorsally is relatively big. And here is a common bile duct distension. On the left, you can see this darker area, that's a common bile duct. And then I did a curvilinear reconstruction from the liver to the duodenum. And you can see that distended bile duct really nicely, just to demonstrate that. If you have too much time, that's what curvilinear reconstruction is for. And here's a cat with a common bile duct distension. I'm sure you see that a lot as well. So you can see all these structures here. And then you can see it here, and on the left you can then see it there as well. And this is the final 2 slides. Diagnosis of gallbladder mucoceles. There was a recent paper on veterinary radiology, very well done. Maybe you're among the listeners. It was a very good talk. And here's an example how this can look like. This was done post-contrast. And you can see this was about an hour post-contrast. That contrast medium has ceased from the vessels. It's still in the liver. It's relatively bright. And this contrast medium drapes over this non-enhancing center, which is the bile duct. And here's another example of a ruptured gallbladder mucocele that we published a while ago. You can see all the distended bile ducts. And also here, this is all gallbladder. contrast medium accumulating dorsally in the gallbladder, but not in the center. So I think this technique of injecting contrast media an hour before works very well, if that is on your level of suspicion. Okay, and that brings me to the end of my talk. And yes, I all wanted to see you at our Congress in Edinburgh in September this year, but we delayed it to the 14th to 17th of September 2022. So we'll do exactly the same thing. We're just going to meet 2 years later. It's the same week. So it will be really fun. Good. I'm looking forward to your questions.
All right, are there any questions, anybody? I don't see any popping up just yet. Okay. All right, well, thank you, Tobias. That was a great session. The next session that we have next week is April 22nd with Dr. Kit Berry, and he's talking about lung patterns to infinity and beyond. And then Tobias will be back in 2 weeks with Abdominal CT Part 2, so that's something we're going to look forward to. You will receive another email with a registration link before next week's session. If you have problems with registering, or if you know anyone else who wants to join, just email academia@vet-ct.com. So the talks are going to be at the same time each week again, and today's session has been recorded. The recordings for today's session and the Albo session will be on our website soon, and we'll keep you updated on that. People have been asking, and the PDFs for the slides are not going to be posted separately. If you have any questions about our resident support plans, please email academia@vet-ct.com. Thanks so much for attending. It's great to see so many people here again. Stay safe, and I hope we'll see you all again next week.
Okay, goodbye.
Okay, bye.